Good evening, everyone, and welcome to our regular workshop webinar from the 100 Black Men of America. I'm Charles Griggs. I'm sitting in right now for our co-chair, Mr. Charlie Hill. He's having a few technical difficulties coming in on air. But I'd like to take this opportunity to welcome you to our workshop. Our webinar this week is on prostate cancer. This is through our Our Voice, Our Voice initiative through 100 Black Men of America. We have a very robust discussion for you this evening, and we're looking forward to it. This event is really going to be focused on a clinical trial study called Compare, which is going to focus on how we do and how we look at clinical trial of African American male participation in research studies. And we have a wonderful panel of guests for you today, to discuss today's event. And we're so happy to have everyone here. And I'm really proud of the fact that we were able to put this together at this particular point in time, because this is another one of the opportunities that the 100 has invested in. Like, we're trying to stay out front. Many of you know that we have a robust prostate cancer education program going on. In the past, we have written our own documents on how to approach screening procedures, and now what we're thankful is that we're branching out into other areas where we can sort of look at how we can best impact outcomes related to prostate cancer. This session is going to focus basically on, again, like I mentioned, Compare. It's intended to bring information about prostate cancer research and its impact on Black men in focus. And we're happy to have our panelists this evening, Dr. Gustavo Rodriguez. He's a U.S. Medical Director for Pfizer. Dr. Curtin DeVille is the Clinical Director and Associate Professor of Radiation Oncology and Molecular Radiation Sciences at Johns Hopkins Kimmel Center, Sidley Memorial Hospital. And Dr. Nancy Mendenhall, who is the Professor and Associate Chair of the University of Florida Radiation Oncology College of Medicine. And the way this will work this evening is that we're going to have our three panelists present, and at the conclusion of their presentation, what we're going to do is, all three of them, we're going to take questions. You'll be able to post your questions in the chat section. Feel free at any time to post your questions, and we will be using their questions in the chat to get our panelists to answer at any point in time. What we'd like to do, though, is to try our best to save most of the Q&A section for the end. That way, we will be able to get as much conversation in as possible and have a more robust conversation. So without any further ado, I'm going to ask Dr. Rodriguez if he would start us off with his presentation and welcome him to our webinar this evening. Dr. Rodriguez.
Thank you for having me. Really glad to be here today to present on this. Trying to see if my slides pull up a second here. Is it pulling my slides up?
Right.
There we go.
Okay, thank you.
Great. So today I'd like to talk about overcoming racial disparities in the treatment of prostate cancer particularly. And I think it's really an important note to really discuss and to really also to identify and really understand some gaps within care that really lead up to this. So if we can go to the next slide, please. So in Pfizer Oncology, we've launched about 15 drugs since 2011 and across other 20 indications. And I think why this is important is that as more new medications do come out for oncology, or say within the oncology space, there's also more health disparities to be also addressed and to be recognized throughout this process, so patients are appropriately treated and captured at the right times. Can we go to the next slide, please? And along with that, it's also addressing the unmet medical needs that do come up, right? So if we see on the top left-hand side, about half of men and about 1/3 of women in the US will develop cancer at some point within their lifetimes. And then if you look at the terms of, in particular towards women, about 1 woman in 8 will be diagnosed with breast cancer in her lifetime. In terms of, on the right-hand side here, about 1 man in 7 will be diagnosed with prostate cancer in his lifetime. And so the challenges that do come with seeing such patients is that there's always going to be an unmet need that has to be fulfilled, particularly with the oncology space, but in these instances between just general population. And it's also to know that even past that, 1/3 of US households do report emotional or psychological challenges that do come and present themselves with cancer. And it's very important to really capture that. So maybe please go to the next slide, please. So in terms of prostate cancer, right, as mentioned previously, about 1 man in 7 will be diagnosed with prostate cancer within the lifetime. And historically, Black men have been having a higher incidence of metastatic castration-resistant prostate cancer, MCRPC, and a worse overall survival than white men. You know, it is a very common cancer. It is the most common cancer among US men and the second leading cause of cancer-related deaths. And so as this historically has been seen this way, I think there may be some new data to really indicate a little bit difference. So if we can go to the next slide, please. Right, so there may be some evidence that suggests that Black patients with MCRPC may have better outcomes in response to prostate cancer treatment compared to white patients. Now, there's a challenge of this, of really understanding the real-world studies that evaluate the overall survival in Black and white chemotherapy-naive MCRPC patients that are treated with NHTs. And as mentioned earlier, right, historically, the understanding is that they've been captured at a more aggressive tumor type and later on down the line than normal. So there may be evidence that supports better outcomes in this instance compared to white patients. Can we go to the next slide? So we were able to look at a study that compared the overall survival in Black versus white chemotherapy-naive MCRPC veterans that were treated with NHTs by looking into the VA database. Now, why particularly the VA database that makes it very unique is where you can capture single payer. It's a large, comprehensive network that allows you to see it all in a very comprehensive manner and capture as much data as possible. So that allows it to have a large and a really strong sample size to really understand comprehensively in one particular large healthcare system. This changes when you kind of start factoring other real-world factors, since other people do have many different insurance coverages. Can we go to the next slide, please? So here, to further go into the study, we were able to identify 787 Black men and 2,123 white patients that were chemotherapy-naive MCRPC patients. And to further drive the point of having such a large sample size to go through, that was out of 369,000 records within the VA system. Now, additionally, through this study, we were able to adjust for potential confounders that would be seen, such as age, race, and those baseline comorbidities, as this is just a very large, comprehensive data set that the VA allows. So can we go to the next slide, please? Now here, the baseline characteristics of the patients that were captured. The mean age of Black men was 72 and white men were 74 years respectively. Why is that important? Is the average age of diagnosis generally is 66 years old for prostate cancer patients. And additionally, within this sample size, the Black patients were more likely to have hypertension, type 2 diabetes, and liver damage abnormalities, but also to have less likely hyperlipidemia, or high cholesterol is one would see it as. So maybe we go next slide. Yep. So here's where it really drives the point home, right? So originally, historically, was mentioning that historically Black patients had higher incidences of MCRPC and overall poor prognosis and overall survival. However, with this data set, we see here that Black patients had a better OS than white patients, with Black men having 30 months of median survival and white men having 26 months. Again, what's really unique to the VA system is you can really capture these patients appropriately and really see them all the way through from beginning to end. I think it's really important when you're able to capture such patients earlier on, and I think it's important in terms of access to care, since these were veterans that were within the VA system here. Can we go to the next slide? Can we go to the next slide? There we go. So furthering down that, here, as you saw in the previous slide, we were talking about the VA database set, how we saw an overall better survival for Black men of 30 months versus 26 months for white men. And when you control for access to care through that single payer system in chemotherapy MCRPC patients, Black patients may have better OS than white patients treated with NHT. We talk about in general with the VA data set, but in general, if patients are able to be captured earlier on, they may have better OS than white patients being seen. And this is consistent that we've seen in prior clinical studies at MCRPC populations. But what's to really drive home here is that so what's needed further in the future is to really have prospective trials to really validate these findings and have an understanding of these racial disparities that are related to the overall outcomes of MCRPC patients with NHTs. And I think there's some challenges to that come up to that. Particularly, there is particularly site challenges for such patients to get involved with clinical trials. Is it within a proximity that's reasonable or challenging to get to? I think also, the general that there could be also mistrust and misperception of the clinical of being participating in clinical studies is also a challenge as well too. Can we go to the next slide? And it's to note that these results of this analysis, they may not be generalizable to other U.S. populations of MCRPC patients that do have other insurances or are without health insurance coverage, because again, this was related to the VA system, VA database that was used. Can we go to the next slide? And so that kind of then drives the point home as exactly patient access and certain things that, for example, at the strong federal and state policies that really allow to capture these patients earlier on. With the disparities of understanding when to provide and to access cancer screening and treatment is how do you capture that patient earlier? When are they able to be captured earlier to really have better outcomes within the system? And sometimes these gaps don't allow that to occur. Additionally, not only is it just about cancer screening as well, but also having ensuring and support insurance policies that ensure patient access to such medicines. Because not only is it cancer screening is important, but also the treatment aspect of it is also another part that's very important. And to just go to the next slide, in pro-patient policies, it can have a profound impact towards cancer care, right? Being able to recognize and have more patient-centric, particularly in being able to understand when is it appropriate for cancer screenings, and also ensure the access to treatment, because the VA database does that. The studies shown from the VA database allows it to really kind of go against the grain of what is originally seen historically of Black men having higher incidences also, but more importantly, having worse OS outcomes that were generally seen historically. And so the OS, there may be a potential to really see that Black men have better outcomes than white patients are seen when appropriately captured earlier on, and when the access to healthcare is more seen at an even level moving forward. And so that's my presentation for today. Thank you.
Thank you for that, Dr. Rodriguez, and we really appreciate that. I'm going to once again ask for those who have questions for Dr. Rodriguez in his portion of the presentation, please use the chat to put your questions in there. We will get to them shortly. Before I pass it over to our moderator, I'd be remiss if I didn't say thank you to Dr. Rodriguez and Pfizer for their continued support of 100 Black Men of America. They've been a great partner with us in our health and wellness issues, our health and wellness needs and committee work. In fact, they sponsored our recent, earlier in the year, we hosted a health and wellness committee retreat, and they sponsored that for us, allowed us to come together and kind of hash out many of the priorities that the 100 Black Men are initiating today. And through that support, we're able to do things like this, continue the webinars that you are watching this evening. And now I'm going to bring in our host and moderator for this evening, after a few technical difficulties, Mr. Charlie Hill. Charlie?
Thank you, Charles. Can you hear me now?
Very well. Got you.
Okay. I don't know what I missed. I was following the slides, but it certainly says a lot about being prepared, and we will move forward. But I want to reemphasize a couple of things and say welcome. I'd like to welcome all of the viewers and participants for tuning in. I'd like to welcome the panelists, and I want to thank them for tuning up. And for our friends at Pfizer, we want to thank you for being an engaged, tune in and tune up partner. So we appreciate that. Again, Dr. Rodriguez, we appreciate your presentation. I'm glad I saw some of it before, and we're going to move forward. I also see Dr. DeVille, and I'm so glad to see you, sir. And I'd like to make the point and tell folk about you, Dr. DeVille. And I had the pleasure, as you may remember, of riding toward the airport, and we discussed, of all things, carbon ion treatment for prostate cancer. That says a lot about both of us, I guess. But one of the things I want to make the point of is that Dr. Rodriguez hit some of this earlier. Dr. DeVille is the clinical director for radiation oncology for Johns Hopkins Chemo Cancer Center at Sibley Memorial Hospital in Washington, D.C., and he's the associate professor of radiation oncology and molecular radiation sciences. I didn't get all of that when we were in the car going through the airport, but I got enough of it to know that his presentation will be outstanding.
All right, Ms. Hill. Well, thanks so much for the introduction and the invitation to participate in tonight's session. Really excited and looking forward to the discussion and conversation, education around prostate cancer and health disparities, and ways that we can address these issues. So I'm going to hopefully try to share my screen appropriately here. And let's see. Okay, can you see my slides, hopefully?
Yes.
Okay, great. And so actually, I also serve as so was mentioned here, the Sibley Memorial Hospital is the location for Johns Hopkins Proton Therapy Center. So serve as the clinical director here for the team. But I'm going to be talking about health disparities and inequities in the treatment of prostate cancer using radiation therapy specifically, and also talk about the importance of minority clinical trial enrollment. So kind of building on the previous talk by Dr. Rodriguez, I always think it's helpful to kind of set some, to talk about some of the definitions, just to sort of make sure we're on the same page, or at least in the way that I certainly am thinking about health disparities. So health disparities, this is a definition from NIH, specifically the National Institute on Minority Health and Health Disparities, refers to differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups. And there are several, numerous, is not an exhaustive list, but certainly in terms of NIH designated US health disparity populations, including Blacks and African Americans, and other kind of demographic groups. When we think of health equity, though, the concept is a little bit different. Disparities can be more of kind of the measure. Equity is more of what we're striving for and achieving. And so health equity, this is a definition, means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good jobs with fair pay, quality education, and housing, safe environments, and healthcare. So it's, while we're thinking about our treatments, we need to also be thinking about how are they distributed, access, and is that in an equitable manner? And actually, health equity is one of our healthcare quality domains, specifically in radiation treatment. We have a very high quality and safety culture. And so we're often thinking about, is our treatment safe? Is it effective? Is it patient-centered? But as we get lower down that list, sometimes we forget, thinking about, is it equitably distributed, should also be one of our quality indicators. And as has been noted, and already we've started this discussion here in this panel, well-documented disparities exist for prostate cancer, specific to the incidence, the morbidity, and the potential mortality, which is the most concerning. And so the American Cancer Society puts out great statistics periodically in terms of what are those numbers, what is the data behind this. And we can see that for prostate cancer, the incidence is higher, as was mentioned. So the likelihood of men to be diagnosed. But what's more concerning is the death rate. When we look in the overall population, the death rate is twice as high, over twice as high for Black men compared to white men. Radiation is a curative treatment that's available for prostate cancer. And so we have the opportunity to address health disparities and try to give our patients the best outcomes. And the literature has noted, some ways in which there are health disparities and inequities in the use of radiation and how that kind of manifests. And we see that in regards to, does the workup occur appropriately in terms of diagnostic imaging and what we call our staging workup. So assessing where's the location of the cancer, what is the status, the potential spread. But also when we look to treatment, and very often Black men in particular may be less likely to even receive potentially curative treatments. There may be a delay, so it may take longer to get to treatment. And also we see disparities in the types of treatment that patients may receive, and even within radiation. And then ultimately the clinical outcomes, as was mentioned. And this is just a sampling, a variety of different studies that have been, reported in the literature specific to radiation. Again, as I said, differences in time from the diagnosis to the initiation of treatment. As we saw with the workup that occurs, also the utilization of certain types of treatment, whether that's the conventional standard radiation with photon therapy or with proton therapy. And that's been seen both at a single institutional level, but also when you look at national data as well. But the good news is, and I think what we also need to be aware of, is that when we receive equal treatment, the literature and the data tells us that our outcomes tend to be equal. And so there is certainly hope that when folks get to appropriate high quality healthcare, that their outcomes can be just as good, even if the incidence of the occurrence of prostate cancer is higher in Black men. And there's a host of literature, both old and new, that have demonstrated this. And Dr. Rodriguez went through a study from the VA, Veteran Administration Health System, documenting that. But also more specifically, when we look at clinical trials where patients receive very specific care and also consistent care, and that acknowledges potential barriers, that patients can have generally just as good, if not better, outcomes specific for Black men. And we've seen that in our national radiation trials and also trials for chemotherapy as well. And so just to sort of pivot a little bit here and talk more about clinical trials, really this is an opportunity where patients can often access new treatments. And so how do we even attempt, we want to continuously do better with medicine, achieve better outcomes. How can we do that? Is potentially through utilizing clinical trials. But unfortunately, utilization and participation in clinical trials is low in the United States overall. And in particularly for minority populations. And you can see here, this is some dated, this information is a little bit dated, but the trends are consistent in that we tend to see very low participation for racial ethnic minority groups. For example, very large breast and prostate cancer prevention trials had less than 5% minorities, whereas about 35% of the US population, in fact, is minority group. And so clearly there's a disparity in terms of the representation, which ultimately impacts our ability to make sure that our results are relevant and appropriate, and that all communities are appropriately benefiting from advancements in medicine and research. And, we don't need to say, but it's worth saying explicitly how important this is at this moment in time as we're in the midst of a pandemic. And if we look at COVID-19 and the racial health disparities that have been noticed, and specifically for Black people dying at a rate 2 times that of white people in the United States, it really emphasizes that when we think about vaccine development, clinical trial participation, that there the importance of participation in these trials so that we know whether the treatments have the same efficacy, the same benefit, the same response, and that all demographics are represented. And I just wanted to provide an example of when we don't have participation by minorities in clinical trials, where we in fact suffer. And so a brief example here specific to prostate cancer was the recommendation that came out a few years ago, was published in 2013 around screening for prostate cancer from the U.S. Preventive Services Task Force, and where they had advised against routine screening. I mean, this was highly controversial. We don't sort of have time to delve into it too much, but the piece that got many folks to, sort of raise their hand or sort of sound the alarm is the concern around the implications for Black men who do have, as we said, higher incidence of prostate cancer, and ultimately who may then be less likely to be screened because of this recommendation. And, noted in that recommendation, the evidence that they used, the clinical trials, there were two main trials, really, one in the US and a European study. They had very low participation of African-American men, only 4% in the US trial, and really none was recorded in the European trial, and unlikely to have had any significant numbers. And so the guidelines that were then delineated did not include, adequate representation of African-American men, and potentially led to them being underscreened, is what subsequently was shown. And ultimately, the recommendation was reversed, not solely because of that, but the guide in the new recommendation, they did acknowledge that given the lack of representation of African American men in these trials, and given the higher risk and incidence of prostate cancer, that it was worth making the consideration about whether to be screened or not, having a conversation with the primary care doctor or the urologist, or any physician for that matter, around the risks and benefits of screening was indeed important for African American men, and that guideline has since been changed in 2018. But just in the last piece here, to talk about what are some of the barriers to participation in clinical trials that we hear of, as was noted. So one may just simply be a lack of awareness of clinical trials and studies, potential ineligibility. And so sometimes trials are a little bit too restrictive historically in terms of what they allow, what other illnesses patients can have. So excluding things like diabetes or high blood pressure in a prostate cancer trial. And so newer studies that hopefully we'll potentially talk about, different study designs that are more inclusive and not so restrictive, really taking on a real world practice setting, such as pragmatic trials, are a way to make sure that we can better assess a broad swath of the population, including minorities. Also removing some of the obstacles to clinical trials, thinking about whether work or transportation are issues, insurance, underinsurance, and additional costs. These are things that we can pay attention to, certainly as clinicians, as we're designing studies, but also things to be thinking about in terms of your participation. Also was discussed trust, comfort level with the physician. These things become important. And this idea of either losing privacy or portrayal as a guinea pig, there's ways to sort of address some of the kind of myths or historical context that's been there, and what are some of the protections that now exist in, such as informed consent, and really making sure that the patient is fully informed and agreeable. So again, ultimately all can benefit from clinical studies. I'm just going to skip over this in the interest of time. Some of the strategies that we can do to increase minority research participation includes activities such as community engagement, and this is a prime example of that. Also doing what's called cultural adaptations, but making sure that we are the materials and the study itself, as we recruit patients, are reflective of the populations that we want to serve, and also making sure that we are broadly targeting and to some extent oversampling our minority groups and Black populations to make sure that they have access to clinical studies and clinical trials, and again, addressing the logistical issues and potentially incentives and disincentives to treatment. And community engagement, it's important to highlight that this is a partnership. It's an exchange of information. So it empowers both the internal and external community, and really goes both ways. It's not a one-way exchange. And we're sort of working on that locally. I'll skip over in the interest of time, but just to summarize, we talked about that health disparities and inequities do exist for prostate cancer radiation, and they can span the workup, the treatment, whether it's delivered or delayed, or the types of treatment. But really, our outcomes when we use clinical trials have the potential to be equal, and if not better, for certain demographic groups, including Black men specifically, has been shown in different radiation and even chemotherapy studies. And we can certainly work to increase our minority clinical trial enrollment opportunities for men. So looking forward to the discussion and conversation with everyone soon.
Thank you, Dr. DeVille. We appreciate your presentation. The next panelist that I would wish to call up is Dr. Nancy. That name, it's interesting. I received a phone call about 6 years ago from Dr. Nancy asking me if there was any interest in participating in some research that she was contemplating and she was working on. And it led to having a chance to meet with her and spend some time and learn from her. And I'd like to just say to you, she's one of the most persistent people that I've ever run into in terms of that particular subject. So we appreciate that. For those who don't know much about her, she's professor and associate chair of the University of Florida's Radiation Oncology College of Medicine. I bring you now Dr. Nancy. Dr. Nancy, are you ready?
Okay, let me try this again. I forgot to unmute myself, and so things did not work. Okay, can everyone see my screen now?
Yes.
All right. Well, first of all, good evening, and thank you so much for the opportunity to share with you some information about the COMPARE trial. This is a trial to determine what type of radiation is best for men with prostate cancer. There are several objectives here to make you aware of potential causes for disparity, potential advantages for proton therapy, potential disparity in access to proton therapy, and the role that the 100 can play to increase access for minorities to this important study. I've no financial disclosures. So the first thing to acknowledge is that the data regarding disparity in outcomes between Black and white patients has been very confusing. But there is a study which our previous speakers have alluded to, which I think is excellent and sheds light on the problems. This is a large study that came out in 2019, and the investigators looked at 3 large databases. The SEER database, which is hospital data from cancer patients from about half of the states in the union, and it represents a broad brushstroke of U.S. practice. The VA equal access centers. So as implied, there's equal access through the VA for Blacks and whites. And then finally, data from the NCI-funded Radiation Therapy Oncology Group randomized controlled trials. And as Dr. DeVille mentioned, on these trials, staging and treatment is per protocol. And so the treatment that the patients receive will be exactly the same, whether they're white or Black. And the outcomes of this study were very interesting. In the SEER database, Blacks had an increased prostate cancer specific mortality rate compared with whites. But in the Equal Access VA database, there was equivalent prostate cancer specific mortality between blacks and whites. And very interestingly, in the NCI-funded randomized controlled trials where treatment and staging was the same, for sure, between blacks and whites, blacks actually had a decreased prostate cancer specific mortality rate compared with whites. They did have an increased overall other cause mortality rate, but the prostate cancer specific mortality was better for blacks. My interpretation of this important study is that there's no difference in prostate cancer outcomes when access is similar and staging and treatment are the same. Now, what's different between conventional radiation and proton therapy, the subject of the COMPARE study? This shows you the treatment plan for a prostate cancer patient. On the left is a conventional radiation IMRT treatment plan, and on the right is a treatment plan with protons. Now, the yellow structure in the middle of each of these represents the prostate. Everything outside that yellow outline is normal tissue, healthy tissue that does not need radiation. Everything that's colored represents an area that's receiving radiation dose. The dark blue is low dose, the aqua is moderate dose, and everything in red is high dose. So you can see right off the bat, there's a big difference between the radiation dose to healthy, non-targeted tissues with proton therapy compared with IMRT, with much less for proton therapy. And in fact, if we quantify the difference in dose, we'll see that the dose to the target is the same for proton therapy and conventional IMRT radiation, but it's the dose to non-targeted healthy tissues is about half what it is with IMRT, conventional radiation. Hypothetical advantages of reducing the radiation dose to normal healthy tissues outside the target are better patient-reported bowel function, fewer complications requiring interventions, safer treatment compression to reduce cost of treatment, safer treatment intensification, and fewer second malignancies. Now, we actually have just recently very compelling data to confirm one of these hypotheses regarding proton therapy, and that is second cancer risk. This is a study from Stanford looking at the National Cancer Database, which captures 70% of all U.S. cancer patients. They found over 450,000 patients who had either conventional radiation or proton therapy, and they looked at the incidence of second cancers. And what they found was overall a highly significant reduction, threefold reduction in second cancers after proton therapy compared with conventional radiation. And in the prostate cancer population, this was actually a fivefold reduction in second malignancies apparent only 5 years after treatment. Now, we don't have this kind of proof of the hypotheses for improvement, the other hypotheses for improved outcomes with proton therapy. So it's very important that we conduct a prospective clinical trial to determine what other benefits might be there from proton therapy and the reduced dose to normal healthy tissue. So the COMPARE study is a prospective comparison of outcomes between parallel cohorts of men treated either with conventional radiation IMRT or proton therapy. It will accrue 3,000 men, and it is large enough study that it can look simultaneously at the incidence of patient-reported problems with bowel frequency and urgency and other quality of life outcomes, physician-reported toxicity and interventions, and disease control, all simultaneously. It's funded by the Patient-Centered Outcomes Research Institute, commonly known as PCORI. Now, unfortunately, we have some evidence. I should say first, a core compare value is that the outcomes of this study be generalizable to all patients, including Blacks and other minority groups. Therefore, minority participation is essential. And unfortunately, we have some evidence that suggests that minority patients may have less access to proton therapy. This is a very large study of the same National Cancer Database that I've already alluded to, looking at utilization of different types of radiation for non-metastatic prostate cancer. And they found that proton therapy was more likely to be used at academic centers, in metropolitan areas, for patients living in zip codes with a higher median household income, and specifically Blacks, Hispanics, and other minority patients were less likely to receive proton therapy than whites for prostate cancer. Now, the reasons for this are not clear, but one possibility is insurance coverage. In this study, they also looked at patterns of proton utilization according to insurance type. And patients with no insurance, self-pay patients, are shown in the blue bars, private insurance in the orange bars, Medicaid in gray, and Medicare in yellow. And what you see is that for Medicaid patients, and Medicaid doesn't cover proton therapy, the proton therapy utilization rate was less than 1% across the years of the study. For the self-pay patients without insurance, the rate actually ranged from about 2% up to 6%. Now, for patients with either commercial or Medicare coverage, the rate increased over the time frame from 2 to 3% all the way to 5 to 6%, showing the strong association between insurance coverage and the likelihood of getting proton therapy. So we've tried to be proactive on the COMPARE study to ensure minority access. And I'm going to show you some of the strategies that we have. First is that we have a large number of sites, 51 participating sites, geographically distributed across the country. The sites shown in triangles provide only proton therapy. Those shown with circles only conventional radiation, and the sites indicated by stars provide both protons and conventional radiation. And the color inside this symbol indicates the demographics of the local site with respect to the percentage of African Americans in those communities. So for example, a blue circle would provide photon therapy, conventional radiation, and there would be less than 10% Blacks in that demographic area, whereas a red area would have larger than 50% African Americans in the population. And the good news is that we have 14 sites providing proton therapy where more than 30% of the population is Black. So this affords us a wonderful opportunity to capture a sizable number of Black patients in this study and provide meaningful results. Now, another strategy that we have in the COMPARE is a very strong patient stakeholder group, including your host, Charlie Hill, and Charles Griggs from the 100 Health and Wellness Committees, Tarek and Calvin Miner, and not mentioned other names you may recognize because they are very strong advocates for prostate cancer. And our stakeholders participate in workshops. They've helped with the study design. They've helped with the funding application, promotional materials, websites, newsletters, and even local site activation. Within the patient stakeholder group, we also have a minority engagement group headed by Charles Griggs of the 100 Health and Wellness Committee, one of your moderators tonight, hosts tonight. And he's created a network from the 100 that is located at Compare sites and serve as liaisons to the minority communities that site serves. And this is an example. This is a picture from a strategic site visit we made to MD Anderson in Houston. And our 100 liaison, Dr. Justin Washington, is shown here. But we've had 100 liaisons at the other site visits as well, and they've been extremely helpful in boosting enrollment and encouraging African American participation. Another thing the Minority Engagement Group has done is outreach, and this is a picture of a Compare booth at a college fair event sponsored by the Alfred Street Baptist Church, and we have members of the 100 Black Men of Prince George's County helping with the boost. And then another thing that we've done is try to create culturally appropriate educational and promotional materials. And I encourage you to go to our website, www.compare.org, to view these materials and see more details about the study and the participating sites. So to conclude, I want to say that we've got an incredible opportunity afforded by PCORI to determine what the best form of radiation is for prostate cancer patients. And we've also got an opportunity to include a significant number of Black, Hispanic, and other minorities in this study, which will make the results of it meaningful to all prostate cancer patients. But we need your help. So please reach out to Charles Griggs to find out how you can get involved, or contact us through the website or email listed below. And I thank you for your interest in the Compare study and your interest in helping us determine what kind of radiation is best for all prostate cancer patients. And I would like now to turn this over to our technical team to show a video about Compare. Thank you very much.
Hi, my name is Tarek, and my dad, like you, was diagnosed with prostate cancer. He was treated back in 2010, and you are probably just beginning the process now. We would like to talk to you about the road you're going down and how a comparative research study can be a part of that journey.
When I was diagnosed, I remember how we tried to decide what treatment made the most sense.
We researched his options. We talked to doctors and other patients, but finding a comparison that just simply said, this treatment is better than that one, was nearly impossible. One way or another, you decided to have a form of external beam radiation therapy.
And I still feel good about that decision.
But here's the thing, you may know that there are two different forms of radiation, proton therapy and photon therapy. They have similar characteristics, good cancer control, and low risk of side effects, but nobody really knows for sure whether one or the other might be just a little bit better, or whether there's really not much difference between the two at all. And that's because there's never been a definitive direct comparison of patient outcomes. And that brings us to why we're talking to you today. Researchers have the approval and the necessary funding to make that comparison, and you'll be given an opportunity to take part in this project. Most importantly, you'll have the satisfaction of knowing that you've helped all future prostate cancer patients have an easier time making a more informed decision. All you have to do is to agree to periodically answer some questions about how you're doing, your quality of life, and allow those answers to be used for this comparison.
That's it. You can even do it online.
Before you begin your treatment here, you'll be asked to participate in Compare, which stands for Comparative Study of Outcomes with Proton and Photon Radiation in Prostate Cancer. This is a big project, and they need 1,500 men for each of the 2 types of radiation therapy.
If you agree to participate, your treatment plan won't change. You and your doctor will decide if you will receive protons or photons, and all of your treatment will be standard of care.
And you'll be playing a critical role in finally figuring out how these 2 forms of radiation therapy compare. Of course, that's what all future prostate cancer patients will want to know. And with your help, they may have that answer soon. Now, this is really pretty easy, and it matters. Researchers have been trying to get to the bottom of this for a very long time, and we finally have our chance to help.
And on behalf of all men who might someday find themselves in our shoes, people like my son here, we thank you for listening.
Okay, I'd like to remind all viewers of that video, that the video was produced for recruitment purposes after diagnosis. And we want to emphasize how important that is. And we're also sensitive to the time. What I'd like to do at this point is ask Dr. Rodriguez, what do we, the 100, need to do to facilitate or to help Pfizer in helping us?
So I think in terms of, in today's conversation regarding disparities, and I think even to both Dr. Mendenhall's and Dr. LaVille's about disparities and particularly clinical trial enrollments, is, an awareness around, which we're trying to do as well too, is around clinical trials, and particularly to engage minority communities to have to be engaged within clinical trials. And I think that's something that's very important that hopefully we can even get to more, because that enrollment is very limited, as we know historically, and it's very important, I think, for the future of just general medicine and treatment going further, right? Because as we're getting closer to having more newer treatments as a whole, as the medical community as a whole, that data is going to be very important to really understand what disparities really live like within certain communities, and also how maybe that even affects treatment as well.
Thank you. I would like to offer up that the 100 has been involved in prostate cancer work now for almost 30 years. I've been involved 20 of those 30 years, and we have learned quite a bit. A couple of things that we learned that I'd like to highlight is that early detection saves lives. We're convinced of that. And the other thing is that we need more advocacy, we need more education, and we need more research. So Dr. DeVille, in your work, what can the 100 do to facilitate, to assist you in the work you're doing? I have a great sense of where your focus is, but how can we help you?
Yeah, no, I think, helping to break down some of the barriers and dispel the myths. Certainly there's a historical context, there's a need. We know the, history with the Tuskegee experiments and those sorts of things. So it's not that this comes out of nowhere. We understand there's a need to sort of rebuild trust, provide information, and, build that relationship. I think where organizations such as this can help is to facilitate that process, finding, trusted providers and folks who really want to make a difference and help the community. Because ultimately, we as Black men are the one who will suffer if we do not participate in the clinical trials. We're sort of missing out on the opportunity to advance our own healthcare. So I think that's important, because a lot of times there's a disconnect in understanding what is the value to participating in clinical research and trials. And I've heard using the term, study can be more, can help folks better understand, whereas clinical trial makes it seems like it's something that, they're being experimented on, some of the things I was alluding to before. Whereas really it is a way to learn and advance the field of medicine, and often to the benefit of the individual patient. It's often how you get access to new and advanced treatments. Certainly a lot of the drugs and other treatments that our colleagues from Pfizer have, but also in terms of the technology that Dr. Mendenhall went through, being able to access, I think of it, the latest and greatest. So really, I think you can help to build that partnership and dispel some of those myths and this lack of information around the benefits of clinical trials and studies.
Thank you, Dr. Mendenhall. What is it that the 100 should be doing to assist you?
Well, I think already much is being done, but when we are about a third of the way through recruitment right now. We anticipate achieving full recruitment at the end of 21, possibly 22. It's been a popular trial with lots of patients signing on. But we really need to monitor all of our sites to be sure that we're getting an appropriate distribution, racial distribution of participants. And that's where the 100 can really come in and help us. I think you can be our liaison in the communities and encourage African American men to ask for an opportunity to go on the trial and to seek out the sites that are doing the study. All of that information is on the website, and Charles is doing a fabulous job in coordinating that effort. But I think that's one of the ways that you can help the most at this point in time.
Thank you. For the viewers who have questions that we didn't get to, would you please send them to the 100 Black Men of America, our headquarters group, and Charles and I will address those questions as best we can and get answers to you. I'm looking at the time. Our time is running short, so I would like to say a couple of things in that regard. We, the 100, wish to close this session with the wish that you and those who mean the most to you have a well and a virus-safe holiday season. From the 100 Black Men of America, and if you don't know, we have 100 chapters, and one of our most important and most active chapters is in London, and we're doing a fair amount of work on prostate cancer there as well. Happy holidays, folks.
Bye-bye.
Thank you. Bye-bye.
Thank you.
Thank you so much.